everybody. We're going to go ahead and get started. Welcome to this year's installment of Controversies in Emergency Ultrasound. The debate rages on. I am Lori Stoltz. I am standing in for Shrikar Adhikari, who many of you know. And for those of you who don't know, he sports a giant mustache his whole life. And his Twitter handle is Sonostache. So I wear this mustache in honor of him. First, our disclosures. Shrikar has lots of disclosures. And we do a fair amount of consulting work for various ultrasound companies amongst all of us, except for D. And so our objectives is that you will better understand these different controversies. You will better understand the literature behind them, both looking at the carotid artery for cardiac arrest and also optic nerve sheath diameter. And you will have better information into how to integrate this into your clinical practice. So first and foremost, I think that we can all agree that recognition of pulselessness by manual palpation is time-consuming and inaccurate. It takes us greater than 10 seconds in a lot of cases. The studies are all over the map about how accurate we truly are in palpating pulselessness. The worst of those studies say that it's only 2% of the time are you able to identify true pulselessness in less than 10 seconds. And then even in a simulated setting, so this simulated setting being an OR, where they have a patient on bypass, even in a simulated setting that is not the chaos environment of cardiac arrest, in those environments, they were incorrect about 50% of the time. And so this is important for our patient care, right? The false negatives lead to unnecessary CPR, and the false positives, even worse, that we aren't giving patients the life-saving interventions that they need. So I'm in the camp that firmly believes that manual pulse checks should go the way of the dodo. They are done for, and we need to move on to something else. Now, the things that people have suggested in this realm. People have suggested that we could use transthoracic echo as a tool to tell us when we achieve ROSC. But as many of you know, like having cardiac activity on transthoracic echo is not ROSC. It's not the same thing. It tells you whether or not there is cardiac activity, but there is a huge spectrum of patients that have PEA. They have mechanical dissociation, mechanical electrical dissociation, and they are generating cardiac motion without perfusion. And so transthoracic echo does not help us in understanding who is perfusing. Also, we get terrible images like this, where you can't see much of anything. You can't tell what's going on. It's difficult to position the probe, especially when you're using mechanical compression devices, and you're interrupting chest compressions in order to do it. We have seen a fair amount of studies that show us that people, even the best trained of us, cannot recognize when we see cardiac standstill on ultrasound. We're very poor at it. And the studies about POCUS interrupting what we know to be life-saving care is very damning. And these studies keep coming. The first one that came out, we were all surprised. And after that, it has now become commonplace knowledge that when we are doing transthoracic echo, we are prolonging our pulse checks. Pulse checks are perfusion. Pulse checks lead to, or pauses in pulse checks lead to less perfusion. And that is the opposite of what we want for our patients at that point in time. So some people have said, okay, well then, let's do TEE. And the problem here is the same, that cardiac activity does not equal ROSC. It is not a replacement for telling you whether or not there is a pulse. And also TEE is, as we all know, difficult to implement because you have to find a way to pay for the probes, you have to train all of the people, and the infection control is onerous, to say the least. So the feasibility of implementing this in every cardiac arrest in every emergency department around the country is incredibly low. Enter carotid ultrasound. It is a surrogate for perfusion. It is available immediately. You get real-time feedback, can tell you whether or not there is perfusion going to the most critical portion of the body, maybe other than the heart, the brain. And it's in a very superficial location. Nobody's BMI should preclude you from being able to get this image. It's easy to access even during a code. You're not in the part of the body where everybody else is trying to be. And it is accurate for the detection of ROSC. So maybe you haven't heard of this. It's somewhat new in the literature that using carotid ultrasound can help you identify ROSC. So there are a couple things that you can look for. First, you could see a sudden increase in the velocity that you see in the carotid. You can also see appearance of diastolic flow between compressions. There's less research done on those first 2 points. The latter point, the inability to fully compress the artery, there's been a fair number of studies that show us that if you are applying the ultrasound probe to the carotid artery during a code, if you are able to compress that carotid artery to the same degree that you can compress the IJ, that person does not have a pulse. If you are compressing the IJ and then the carotid remains uncompressed, that person probably has a pulse, and you may even see pulsations. You may not, but you don't need the pulsations. It's just the compressibility. Compressibility is something that all of us can do. Compressibility is something that my nurses do. My technicians do it. They're doing it all the time to look to see if something is a vein versus an artery. So it's a very easy skill to do. And it's pretty darn accurate. We're talking about sensitivity and specificities that are in the 90s. And it's not just OR-based studies. They have done OR-based studies, but there have also been studies done in the emergency department that look at this. It's still in pretty early stages of research that tell us whether or not this is going to be long-term feasible, but we know that it is accurate. A couple studies have shown us that. We know that it is faster than doing manual palpation. So we're looking at differences of 1.6 seconds versus 3.5 seconds, differences of 2 seconds to 5 seconds. And in this scenario, those seconds do count. And so the first studies have shown us that you can do this with compression alone, but I think that there's a world out there where we are going to be looking at flow velocities. I think this might be more technically challenging, might be more in the realm of us ultrasound trained folk, but something to explore, something that we should go down that path and look at it further. And is it truly feasible? I hate that we always put the medical students out there as if a medical student can do it, then it's feasible. but yes, anybody can do it, and even they're coming up with even devices that are wearable ultrasound, where you put a device over the carotid. Now, I question whether or not they're going to be able to develop this kind of technology that evaluates the flow within the carotid, despite all of the artifact that would occur in a cardiac arrest when you're moving them around, when they're getting compressions. But I think it's fully possible. There's several studies that have started looking at this. So in summary, carotid ultrasound is easy to perform, it's feasible, it's accurate, it decreases our pulse check times. As the ultrasound folks in our sites, we should be the ones that are pushing the needle forward, and I think that this is an area in which we should keep going. Now it's your turn, Dee. She's going to tell you why I'm wrong.
Hi, everybody. I'm Dee Coney Bear. So I thought I was going to be debating Shrikar with his formidable mustache, but instead I have the privilege of debating Dr. Stoltz, who is my very formidable opponent. So I hope by the end of today I'm able to impart a little bit of evidence to suggest the opposite of why we shouldn't be looking at the carotid in cardiac arrest. So let's start with the issue of ROSC. We are still kind of looking at a qualitative assessment on whether or not there is a pulse. So like Dr. Stoltz says, we're looking for either incompressibility of the carotid artery or that pulsatile appearance of the carotid. At the end of the day, this is still a qualitative assessment, and now we're using our eyes and not with our fingers. We're still led to the same issues we have with any potentially subjective judgment. And so in this particular image, this is taken from Smith et al. The study group was split half and half on whether or not this person had ROSC. And on average, it took 17 seconds to make that determination. And so what the studies have shown is the more robust the pulsations, the better the agreement. And that's truth. Subtle things are going to be subtle and robust things are going to be more obvious. And I will argue that in most of our patients who, with that initial ROSC, we may not have the most robust pulsations to give us that definitive answer. Dr. Stoltz and Dr. Adhikari had cited a couple of um, papers that looked at the difference between manual palpation and carotid ultrasound. And the differences were 2 to 3 seconds. And in these series of papers, the differences were less than half a second. And so, yes, there is a statistical difference, but are we just splitting hairs? Does it really make any clinical difference? Does it make any difference to the patient? I'm not so sure. And my opponent has asserted that we can use the carotid to monitor the efficacy of CPR, and that carotid flow can be a surrogate of coronary and cerebral perfusion. And the feasibility has been demonstrated by medical students and patients. However, what those studies didn't look at, again, is whether or not that made any difference to our patients. So in this prospective study, where they looked at carotid flow and tidal CO2 in patients in cardiac arrest, they found no correlation between peak systolic, in diastolic, and mean flow velocities in those that achieved ROSC and those who died. And carotid flow was not found to be an indicator of any type of patient's prognosis. And next, I'd like to examine the patients who were excluded from the carotid studies. Most of these studies excluded patients with known carotid stenosis or any known carotid pathology, such as dissection or any surgical intervention. A lot of these studies also excluded patients if they were unable to obtain carotid images within the first 5 cycles of CPR. So the exclusion seems pretty obvious. We exclude carotid stenosis because calcifications and stenosis can affect the way that the carotid looks and how compressible it can be. And I think this is a significant limitation. One study went even as far as excluding patients who were older than 65 due to their risk of atherosclerotic disease and carotid pathology. So we're left with patients who are relatively young and patients who have relatively healthy vessels. Are these the patients that are really representative of who we're seeing in cardiac arrest? I don't think so. And overall, there is a paucity of studies. There's only a dozens or so studies in humans looking at this topic in cardiac arrest, in real life cardiac arrest. And they're most either retrospective or image review. There's only a handful of prospective human studies. There are more studies looking at TTE and TEE in cardiac arrest than carotid ultrasound. And I think there's a couple of reasons for that. One of the reasons is that it's actually difficult to do logistically. When we have a patient who comes in cardiac arrest or peri-arrest, we usually have someone who rushes to the airway. We usually have someone standing next to them, helping them with the airway. We have someone gaining vascular access. We have someone putting them on the monitor, on pads, and doing compressions. The head of the bed is pretty crowded, and it's really tough to fit yet one more person to do that task. And even if we sign the person at the head of the bed to look at the carotid, they might be already holding an ET tube, they might be bagging the patient, they might be trying to drop a TEE probe. They're going to have to grow a lot more arms in order to accomplish yet another task on their to-do list. And yes, even if we can see that carotid ultrasound can tell us whether or not the patient has ROSC, it gives us minimal additional information. This was a patient that came in respiratory failure. We were told by EMS that the patient was satting 50% and they couldn't get a blood pressure. So my next question was, do they have a pulse? And this was a situation where I physically could not get to the head of the bed. We were transferring the patient over. My PA was bagging the patient. I was able to plop a probe in the subxiphoid area and get this image. I just want to point your attention. I put the patient as John Doe because this patient literally came in and we haven't registered the patient yet. So this looks like organized activity. Patient probably has a pulse, but I thought I saw something weird in the right atrium. So I kind of took another look and saw this clot in transit. So before the patient was even registered, we determined why he was presenting in such terrible shock. And I don't buy that carotid ultrasound is so much easier than TTE. This is not supported by literature. This is not supported by Srikar's study with Dr. Gaspari. In 793 cardiac TTEs that they've done in their cardiac arrest study, it took less than 5 seconds to obtain all of the images in all of the groups. And another remarkable finding from their study, and one of their major conclusions, was that looking at the heart caused providers to pursue interventions that deviated from the ACS protocol that proved to be ultimately life-saving. And that would not have been possible had the focus been on the carotid. And so I'll end with this. If we're going to wax poetic about the best ultrasound modality to use in cardiac arrest, why not gather as much information as possible? Ultrasound allows us to ask more complicated questions than just a yes or no. It allows us to dare dream about treating the underlying cause. We rarely make decisions in isolation. So we shouldn't isolate ourselves to just one vessel when facing existential complexity. All right, that's it. But at the end of the day, I'll still probably do whatever the card tells me to do.
My name's Stephen Haight. I'm from UCSF Fresno. I'm the director of emergency ultrasound there. And I have multiple personalities, so I will be debating myself during this lecture. We're originally going to do 40 minutes, so we shortened it down to 20. So it's going to be a rapid fire review of kind of the pros and cons of using the optic nerve sheath to detect increased intracranial pressure. So just as a reminder, kind of the overall way to do this, I'd say most people, we have them in a semi-recumbent position. They have a lot of neutral gaze, so they're looking straight ahead. You're getting an axial or visual axis view of the eye, and then you're locating the hypoechoic optic nerve posterior to the globe. And there's this 3 millimeter measurement that everyone kind of uses, where you're measuring back and then across orthogonally to get an optic nerve sheath diameter. And if you have an elevated or increased optic nerve sheath diameter, that likely indicates you have increased intracranial pressure, which is greater than 20 millimeters of mercury. And the rationale for using the optic nerve sheath for this purpose is the optic nerve sheath is an extension of the subarachnoid space. So increased intracranial pressure inside the brain, inside the ventricles, will then transmit to the optic nerve sheath, which will cause dilation. And there's a pretty strong positive linear correlation between increasing optic nerve or intracranial pressure and optic nerve sheath diameter. The thing is, though, it's not telling you what's causing that increase in intracranial pressure. So what are some of the pros for the sonographic assessment of the optic nerve sheath? It's very quick to do. The eyeball's pretty accessible in most patients. If they don't have prior eye surgery, it's usually pretty easy to get images. And the benefit of that is, if you have a patient that you're really worried is maybe going to herniate from increased intracranial pressure, you can get a rapid detection of that process that's going on and start initiating treatments, maybe hypertonics, mannitol, hyperventilate the patient, etc. You can do a bedside assessment, which can be very helpful in unstable patients. Sometimes patients are too unstable to go to CT, and often are very not stable enough to sit in an MRI machine for 30 to 40 minutes to get a brain MRI. Even a 5-minute CT can be difficult. So in patients that are pericode or just very, very hemodynamically unstable, it can be very helpful. It's non-invasive, so putting in an EVD or an intraparenchymal catheter to measure intracranial pressure directly is fraught with potential complications, infection, hemorrhage. Whereas if there's a non-invasive method of finding it, you can elucidate that without those risks. It's easily repeatable, so this can be helpful in the ICU setting where you can do your initial, get a value, and then as you initiate therapies to lower their ICP, you can repeat it and see is there a change in the optic nerve sheath, and that can be beneficial compared to going back to the CT scanner multiple times. And in resource-limited settings, in maybe global health applications where CT is not available, or in the scary world where your CT scanner breaks for a couple hours and you don't have a CT scanner, it can give you some information. So that all sounds very easy, right? Measure it, get increased intracranial pressure, and you're done. So it's a little more complicated than that, and that's the reason why it's on this controversies topic. We still can't agree on a lot of things here. So there's a lot of things that will influence the size of the optic nerve sheath that haven't been well studied. There's stuff like application of positive pressure ventilation can cause an increase in the sheath diameter, cervical collar application in trauma patients. There's some evidence to show that male sex and older age are associated with larger sheath size. And then there's technical factors, whether it's the patient's position or their gaze direction, or even the probe frequency you're using. Some studies have used probe frequencies that don't allow adequate lateral resolution to really see that edge of the optic nerve sheath well. And then there's also the fact that, we're potentially not even measuring the optic nerve sheath in some cases. So Capetti et al. Showed in this study using color Doppler that if you follow the course of the central retinal artery using color Doppler, what we're actually seeing a lot of the time is probably artifact from the lamina cribrosa, a shadowing artifact. And the actual course of the optic nerve is more serpiginous and likely smaller than what we think it is. And then there's the big issue of operator dependence. So there's a significant amount of intra-observer and inter-observer variability. There was a good systematic review by Hassel et al. In 2022 that showed that the standard error of measurement can be up to 0.4, which means that if you get a measurement of 5, the 95% confidence interval for that measurement could be anywhere from 4.2 to 5.8, which when we're talking on like a millimeter of difference being less than 5, almost certainly normal, greater than 5.8, almost certainly pathologic, you really want to be accurate and have a very narrow variability there. And where does all this come from? So the biggest source, I think, of this confusion on how to use the optic nerve sheath is the lack of measurement standardization in the literature. So there's kind of two different echogenic signatures that have been described for the optic nerve sheath. On the left there, you can see this kind of stripe hyperechoic appearance. And then on the right there, there's this just hypoechoic optic nerve with no striping surrounded by retroorbital fat, which is, in my experience, the more common signature that I see. So it's pretty easy to know how to measure the one on the right, but when you get that signature on the left, you'll see that in the literature, there's 3 different caliper points that people have used to delineate the optic nerve sheath in their studies. So then when you pool that into meta-analysis, you get this varying cutoffs for the measurement and what is normal and abnormal. And then there's the issue of the 3 millimeters. Across the literature and all of these studies on the optic nerve sheath, some people are measuring from backwards from the level of the retina, some from the lamina cribrosa at 0.2 there, and some from the beginning of the hypoechoic optic nerve itself. So if you're not measuring from the same spot, your output is going to be different than other people potentially. And then there's a lot of variability in the imaging axis used, patient body position, frequency and transducers. There's quite a few more in addition to that. So sensitivity, this is meta-analyses from the past 10 years roughly. Actually, this is the last 5 years. Your sensitivity is about 82 to 92% to detect increased intracranial pressure, which if you think about it, if you're worried about it for these, if you have a moderate to high pretest probability, it's not sensitive enough to rule it out. So you're probably going to have to get some additional imaging. And it's also looking at it in terms of is it elevated or is it not in a categorical sense. It's not actually looking at it. It's not giving you a value. It's just telling you it's elevated, which there may be some utility in knowing an actual value. Specificity is about 74 to 91%, which is, there's a multitude of conditions that will give you an elevated optic nerve sheath that do not give you increased intracranial pressure, necessarily optic neuritis, masses in the orbital cavital sinus. And one thing that I find very salient to EM is a lot of these studies exclude patients that have orbital or facial trauma. So for our patients, we're worried about increased intracranial pressure due to trauma. Some of this data may not be generalizable to those patients. And the biggest issue I think that a lot of people encounter when teaching this or learning this is like, what is the cutoff? And going back to those earlier points, since there's such variability, heterogeneity in the literature, when you do meta-analysis on all of that, you get different conclusions depending on what you include in the meta-analysis. So you'll see anywhere from 5 to 6 to 5.8 to 5.7. What I think is clear is greater than 6 is definitely abnormal. But that optimal cutoff is even more unclear as you go into different patient populations, such as younger patients, especially young children who have a smaller optic nerve sheath. And balancing that sensitivity specificity is always an issue. So my take on the optic nerve sheath is it kind of has limited utility in its current setting of their EM and critical care applications due to that uncertainty of what's a cutoff, the multiple factors that can influence variability, and it's not really, sensitivity is king in emergency medicine. We want to rule out conditions. So if it's not sensitive enough in patients that we're worried have a certain process, then it's not really giving us information that we can act upon. So I think one thing that could be done to fix this is to kind of reboot the literature and have a standardized measurement methodology. This is how we're measuring it. This is what 3 millimeters back from this, and kind of replicate studies to get a more homogeneous literature source to kind of elucidate the final question.